Good morning, everyone. I'm William Lyman. I'm the current research resident for the Division of HPP Surgery at Carolinas Medical Center in Charlotte. And today I'll be presenting our comparison of our two different minimally invasive approaches, laparoscopic and robotic, for left pancreatectomy. I have no relevant financial disclosures that funded this study, nor do our co-authors. So I'll talk first about the current state of minimally invasive left pancreatectomy. I'll talk about our design and results for our overall cohort, as well as specifically for pancreatic adenocarcinoma. I'll give a brief cost analysis at the end, and then talk about conclusions that we have drawn at our institution, as well as future directions. So the first reported case of a minimally invasive left pancreatectomy was in 1996. And over the last decade, we have seen more and more both laparoscopic and robotic-assisted left pancreatectomies performed for both benign and malignant procedures. While numerous studies have shown advantages over the open approach for similar patients, studies comparing modality or differences between a minimally invasive technique have been mixed to date. So we wanted to compare our single center experience because we do perform about 70% of left pancreatectomies at our institution, either robotically or laparoscopically. We also wanted to perform an additional subgroup analysis of those patients undergoing resection for adenocarcinoma to ensure that we were getting adequate short-term oncologic outcomes. We hypothesized that we would find no significant difference between the two groups. So we first performed a retrospective evaluation of a prospectively maintained REDCap database that spanned from 2008 to 2017 and identified 249 minimally invasive distal pancreatectomies. Two of these patients were excluded as they were classified incorrectly into the database, and they were all classified by intention to treat. So for example, if one of our robotic-assisted cases was converted to a hand-assisted laparoscopy and it was converted to an open procedure, it was still classified and statistically analyzed as a robotic-assisted procedure. We identified 139 laparoscopic left pancreatectomies, 35 of which were for adenocarcinoma, and 108 robotic left pancreatectomies over the same time period, 23 of which were for adenocarcinoma. Cost data was limited to 2013. It's an institutional database or an administrative database that was only valid for OR supply costs. We used the combinations of Pearson's chi-squared and Wilcoxon rank sum tests out as appropriate in statistical software. So overall, our demographics between our two major operative groups showed no statistically significant differences. BMI was on average around 29. About over 20% of patients were current smokers or diabetics. And our indications were a little bit different than some other institutions. We have a much higher rate of minimally invasive left pancreatectomies performed for pancreatitis at our institution, with about 38% of our robotic cases and 31.6% of our laparoscopic cases, and a little bit lower incidence of adenocarcinoma. Intraoperative results of note included a longer operative time in the robotic group with about an hour shorter procedure in the laparoscopic cohort. Spleen was preserved in 31.5% of cases versus 8.6% in the laparoscopic group. However, I will note that I was unable to determine intention to originally preserve the spleen based on evaluation of the operative reports. Tumor sizes were above 4 centimeters in both cohorts, and conversion to laparotomy was equally low at 4.3% in the laparoscopic group and 1.85% in the robotic group. Looking more specifically at our conversions, we employed the hand-assisted approach in 47.5% of our laparoscopic distal pancreatectomies. I was unable to determine original intention to treat, whether the procedure was started laparoscopic hand-assisted or converted reliably. However, all of our robotic-assisted procedures start as a pure robotic procedure, so about 10% of those were converted to a hand-assist laparoscopic procedure. Our overall results were similar between groups for short-term outcomes with equal 30-day mortalities and 90-day mortalities, length of stay of approximately 5 days between groups, median length of stay of 5 days. Our 30-day readmission was surprisingly higher, and I'll talk a little bit about that later, with 25% being readmitted in the robotic group versus 14.4% in the laparoscopic group. Pancreatic fistulas were equivalent at about 20% for distal pancreatectomy for both cohorts, and these are clinically significant grade B or C. Specifically for adenocarcinoma, we found the total operative time, again, was significantly increased by approximately 1 hour when approached robotically. We did surprisingly find a higher incidence of pancreatic fistulas in our robotic-assisted approach for adenocarcinoma. However, this is a fairly low sample size, only about 23 robotic-assisted patients, and we consider this is probably a type 2 error, given our equivalent rate of pancreatic fistula in our larger cohort. Pathologic outcomes were similar between groups, with tumor size, lymph nodes evaluated, T3 status, N1 status, and R0 resection similar between both laparoscopic and robotic approaches. 2-year actuarial survival was similar between groups as well. When we looked specifically at the costs, and again, these are limited to only 2013 and onward, we looked at both direct supply costs and direct case supply costs. Now, what that means is the actual number of supplies used and the cost for each supply, and then direct case supply cost adds in labor as well. And so we did see a statistically significant increase in costs for our robotic-assisted procedures. However, when you look at the mean for direct case supply costs, it's only approximately $200 more expensive, and this is raw operative costs. So while each modality displayed had slight advantages, either in intraoperative or postoperative outcomes over the other, the advantages, in our opinion, tended to balance themselves out, especially in key outcomes between laparoscopic and robotic left pancreatectomies. We did have a higher rate of readmission, 30-day readmission in the robotic left pancreatectomy cohort, and we think that some of this may be attributable to the higher rate of chronic pancreatitis that was treated with robotic-assisted left pancreatectomy at 38% versus 30%, as many of these readmissions were for abdominal pain postoperatively. However, this does not explain the approximately 10% difference in readmission. So at our institution, this difference of slightly over $200 in mean operative room supply cost per case is likely not financially significant when evaluating overall hospital cost, but we're working on getting more thorough databases for cost throughout the entire stay. So this is a single center retrospective study. The majority of robotic cases were historically performed by a single surgeon up until the last 2 years. 2 have been performing robotic-assisted procedures. This is a high-volume center, and it may not be easily transferable to lower volume centers, as we've seen in previous studies combining, looking at pancreatic outcomes. And then again, this is a limited cost comparison, and we'll need to have a much more thorough cost evaluation. And so overall, we found that outcomes were similar at our institution between robotic and laparoscopic approaches to left pancreatectomy. We view the laparoscopic and robotic platforms as tools for the surgeon, and we leave the choice of operation or operative intervention up at the discretion of the operative surgeon. And regardless of the operative approach, surgeons should continue to perform minimally invasive distal pancreatectomies when feasible. I thank you for your attention, and I'll take any questions at this time.